Good morning, good afternoon, and good evening. Thank you for joining us today for this PATH Live Forum. Today's conversation is called COVID-19 Creates New Opportunities for TB Care in Sub-Saharan Africa. A very timely and important discussion. My name is Nanthalile Mugala. I am the Chief of the Africa region at PATH, and I'll be moderating today's conversation. We'll start by going over a few logistics. Firstly, we want to hear from you during this conversation, so please share your questions and comments with us by submitting them in the chat or the question and answer box at any time throughout the presentation. I will be monitoring your questions, and we will dedicate at the end of the hour time for question and answer session. I also want to invite you to join the conversation online by using the hashtag #PathLiveForum and tagging us at PathQuick. This call is being recorded and will be distributed for those unable to attend. I see that we have participants joining us from all over the world. That's really exciting. Philanthropists, government representatives from the private sector, and my peers in public health. I want to thank all of you for joining and for all that you're doing for our communities, both here in Zambia and all over the world. Before we dive into the conversation, I want to share a little bit about PATH for some of you that might be less familiar with what we do. We are a global team with a footprint in more than 70 countries. We have offices in over 20 countries, with 11 of these being in the African region. Additionally, PATH has over 1,400 staff across the world. Our mission is to advance health equity through innovation so that all of our communities can thrive and that people can live productive lives. For more than 40 years, PATH has been a pioneer in transforming how the world thinks about and engages in public health, even before the uncertainties caused by COVID-19 pandemic. As PATH, we are committed to working in partnership with governments and ministries of health to strengthen public health response in communities and support creation of strong and sustainable health systems in order to fight infectious disease, respond to emerging health threats, introduce vaccines, and develop policies, and much, much more. My colleagues today will talk about our work the work that we're doing in controlling TB in Zambia. At a global level, we advise normative bodies, coordinate multi-stakeholder efforts, and evaluate programs, products, and policies. Right now, we are part of the fastest global effort to scale up and introduce a novel vaccine for COVID-19. And with that, I'm excited to jump into today's conversation. We know that COVID has devastated communities everywhere, but it has also taught us some lessons about how we can adapt to make services better and more accessible for everyone. Today, we'll talk about how COVID-19 creates opportunities for TB care in Sub-Saharan Africa. I'm delighted to kick off things off today. I am delighted to be joined by Dr. Charlotte Colvin, who is a senior TB technical advisor at USAID Washington and leads the TB team's work in pediatrics and quality of care. She also provides backstopping support to USAID missions in Zambia and Mozambique. Charlotte, thank you very much for being with us today.
Thank you so much, Nanthalile. I'm really delighted to be joining you today. Thank you so much for the invitation, and I'm looking forward to hearing from our colleagues. As we all know, COVID is affecting TB services at all levels. We see effects at the global, national, and at community level. And I think all of us have seen some real personal effects too. We know of colleagues in South Africa, Philippines, Pakistan, Afghanistan, and Bangladesh who have actually died of COVID, and others who have fallen ill, but thankfully recovered. So we see it at a very personal level and in our work, this impact of COVID on TB. And many of you know of a modeling study that was commissioned by the Stop TB Partnership that estimates we could lose up to 5 to 8 years of progress in the fight of TB because of COVID. And we could see an additional 1.4 million TB deaths between 2020 and 25. The global TB report that came out a couple of weeks ago also describes some expected direct and indirect impacts of COVID on TB. We could see an additional 200,000 to 400,000 TB deaths just this year due to disruptions of COVID. And we could see increases in the number of TB affected households that face catastrophic costs due to the COVID impact on the economy. And we need to anticipate things like the impact that we will see in malnutrition due to the economic impact of COVID that could really impact TB incidence over time. So we see these direct and indirect effects that we need to anticipate. I just want to spend a couple minutes telling you a little bit about the information that USAID is collecting from missions on a regular basis. We're sending out a survey to our colleagues to try and understand in real time the effect that COVID is having on TB services. So I'll just share with you a couple of findings. About half the countries of the 23 countries that we support with TB funding from USAID are reporting that expert machines have been diverted for COVID testing. And then more than 80% of those countries are reporting that healthcare providers and TB services are being reassigned to support COVID response. More than half of the countries are reporting reductions in the number of beds available for MDR TB inpatients due to reallocation of those beds for COVID response. And we're also hearing that domestic funds for TB services have been reallocated to the COVID response in about half of the countries where we work. So we're seeing this very, very clear and sort of quantifiable impact on the TB services. And I'm sure we'll be hearing more about that from Dr. Lungu a bit later. And just in terms of notifications, we're already seeing, if we compare January through June of 2019 with January through June of 2020, we're seeing notifications go down. Indonesia, Bangladesh, Philippines, and Ukraine have all reported a 25% decrease in overall TB notifications. In Afghanistan, Zimbabwe, and Philippines are reporting a more than 25% decrease in notifications among children. And we're also quite concerned to see that enrollment on DRTB treatment is declining in Bangladesh, Afghanistan, and Zimbabwe as well. But at the same time, we recognize that COVID response is integrating very well with the existing TB services, and that in most places, TB services are an important resource. If you were at the union meeting last week or the WHO NTB summit, you probably heard our division chief, Sherry Vincent, say, and I think this is really an important note, that we are talking a lot about what we can learn from COVID. But we also know that COVID's learning an awful lot from TB, and that in many places, it's the TB response and the existing TB services that have really formed the backbone of the response to COVID. We know that the existing diagnostic networks, the infection control activities, contact tracing, and the existing data systems, and in many places, our communication materials, which have been very rapidly adapted to add COVID issues to the existing TB work. So we know that we really can't continue with business as usual in the wake of this epidemic as we look at the intersection of these two illnesses. both from an epidemiological and a programmatic standpoint. And we're going to have to continue to innovate and adapt programs to aggressively address TB. While COVID is having a devastating impact on TB, there are some lessons that we're already taking from the urgency of the COVID response and the accompanying resources that have come with it that we might be able to use to enhance TB services that have lagged. So again, in the area of contact investigation, are we training more people at community level to actually conduct contact investigation because of COVID? And can we leverage that investment to really improve the coverage of contact investigation for TB? What additional investments in surveillance and data systems for COVID might actually help us in the TB community improve our own surveillance and reporting? And would we be able to do things like really bolster healthcare worker surveillance or surveillance of specific risk groups with these investments that we're seeing in the COVID surveillance? And then specifically for activities such as specimen transport, would we be able to harness or leverage investments in specimen transport that are happening because of COVID to really benefit the TB program? We know that in many places, specimen transport is somewhat spotty. It doesn't have high coverage. It's often tied to specific projects. It's not scaled, and maybe there's an opportunity there. I don't know. And again, I look forward to hearing more from our colleagues in Zambia about these types of things. But as the world comes together to tackle COVID-19, it's really important that we continue to protect the lives of people with TB and our investments in TB. And we should work really hard to avoid reversals in the gains that we've made. USAID is really eager to do our part in helping programs get back on track and to account for the setbacks that we're already seeing and to further accelerate progress towards reaching the UNGA targets. And so with that, I really look forward to hearing about the experiences in Zambia and the insights from the Ascent project. Thank you.
Thank you very much, Charlotte, for those very insightful remarks. And certainly, we are learning a lot from the COVID response, but like you rightly said, I think there's a lot that the COVID response is also learning from what has been done in the TB world. So thank you very much for that. I want to take a minute to talk a little bit more about the current state of TB care and opportunities ahead of us. And some of this actually Charlotte has touched on. In the past 10 years, as you all know, we have made significant progress in controlling TB. Since 2000, tuberculosis mortality had declined from 2.4 million persons to 1.4 million. TB incidence equally fell 9% globally from 2015 to 2019. And in 2019, the US Food and Drug Administration gave approval for Pretomite, the third new TB drug of the decade, after a generation without a single new treatment option. And then came COVID-19. The World Health Organization and the Stop TB Partnership warned of significant disruptions to TB control, including serious reductions in patient notifications in the highest burden countries, and hundreds of thousands more deaths from TB in 2020 alone. But if we address these diseases together, COVID and TB, and not as separately funded and fueled epidemic responses, then we may have a chance. Here are just a few examples, some of which Charlotte highlighted, of how this is already happening. Digital chest x-rays can be used to screen for both diseases, TB and COVID-19. Contact case tracing applications can be used for both. Rapid diagnostic platforms can be used for both. And even the simple mask, which was once a stigma for patients with TB, is now being used universally. And so, most people can use the mask without any fear of being stigmatized at all. Today, we are very fortunate to be joined by a fantastic group of speakers who will share more about this through a round of lightning presentations. We'll have a lot of time after the presentations for questions and answers. So please just keep your questions and answers, and these will be tackled at the end of the presentations. We have 3 speakers lined up today. Dr. Patrick Lungu, who will be the first speaker, is the manager for the Zambia National TB Program. And he has, as you can imagine, he knows firsthand the impact of COVID-19 on the TB response and develop strategies to respond to this at a national level. Dr. Victorian Sonder is leading the USAID funded Eradicate TB project, which is being implemented by PATH in Zambia, which maintained treatment success rates fairly well despite the service disruptions surrounding COVID. So working very closely with the Ministry of Health, ensuring that some of the gains that we have made in the TB program are not reversed, as Charlotte had highlighted. This is critical. And then we have Mr. Kristian, who has been leading the effort to launch a multinational research program to improve TB treatment outcomes using cutting-edge digital technologies. So thank you all, our presenters, for being with us today. The presentations will be about 5 minutes for each of the presenters. So to begin with, I will start with Dr. Lungu. Dr. Lungu, I would like to start with you. Can you please share your perspective with us about how COVID-19 has affected TB control in Zambia? What has been done to date in response? Thank you.
Thank you very much, Madam Chairperson. I'd also like to congratulate the entire PATH family for organizing this important symposium. I would like to say good morning, good afternoon, and good evening, colleagues. As introduced, I'm Dr. Patrick Lungu, the National TB and Leprosy Program Manager for Zambia. So I'd like just to share with you our experience as Zambia. So this is from the ministry perspective and also in collaborating with our cooperating partners. I think I'll be more illustrative if I could share a few statistics. Chairperson, allow me to share my screen if that's possible. Yeah. I'd like to get a feedback if you're able to see my screen.
Yes, we are.
Thank you very much. So ladies and gentlemen, what I'm sharing with you is the Zambian chapter of how we've responded to the TB epidemic amidst the COVID pandemic. So what you are seeing here is our weekly data. So just to share with you that Zambia has introduced the weekly TB reporting of key indicators, and the key indicators being the number of presumptive TB patients being identified, the number of TB patients that are bacteriologically confirmed and notified, as well as those that are clinically diagnosed, and mortality data, as well as our TPT data and contact tracing. So what I'm sharing with you is the data as of week 1 of this year up to week 37. So just to share with you that when we started at the beginning of this year, we started recording an increase in the number of cases that were diagnosed until in week 12 when Zambia notified the first cases of COVID-19. Thereafter, with the measures that were put in place to actually prevent the further spread of COVID-19, we saw that the turnout at OPD services, the numbers reduced. This inadvertently resulted in the reduction of the TB notification. And we were fortunate enough that the Stop TB Partnership did share their estimation of the possible losses that the TB programs across the globe were going to experience, and we got consent. We were alert enough to notice this through the weekly reporting. And with what I'm sharing with you is that the numbers really declined. So in 4 weeks post the notification of the first cases of COVID, we recorded an 18% decline in the TB notification as here shown. And we got concerned and said, should we let this continue? And together with our cooperating partners, we did a wide consultation and we said we needed to do something about it so that we do not lose our gains totally. And there, ladies and gentlemen, we launched what we are calling the TB Situation Room. And in the TB Situation Room, we actually track the weekly TB notifications and the key TB indicators as earlier shared. So in week 19, we launched the TB Situation Room. And I would like to share that the people who attend the TB Situation Room are all partners working in TB. Eradicate TB has been key and very instrumental in this whole process. And the districts as well as facilities do participate in these meetings. And in these meetings, rather than data, we track also the emerging issues that may pose a threat to the services with regard to TB. So here are the results of us creating the TB Situation Room. So ladies and gentlemen, we now have data of up to Q3 of this year. And when we compare the 3 quarters of last year and the 3 quarters of this year, the first 3 quarters of last year and the first 3 quarters of this year, what we are recording is that we have actually recorded a positive increase in the number of cases of TB that have been detected and linked to care. So what we are saying from this data is that not only has Zambia sustained the TB activities amidst COVID, but also we are recording the best performance in the history of the TB program in a quarter through these interventions. So how did Zambia achieve all this? So one of the measures that we put in place is that we actually developed guidelines which we are calling the essential guidelines for continuation of provision of essential services. And these were launched on a platform such as this one to all the facilities. So we did the capacity building, we did a readaptation of how services needed to continue both at facility and the community level. I'll talk about the community service delivery. We did minimize our contact tracing to a targeted approach. So we had to stop the door-to-door because we needed to stop the transmission of COVID-19. So we only visited households where there was a positive TB patients, bacteriologically confirmed TB patients, and we screened the household from that setting. And what did we do at facilities? At facilities, we enhanced the infection control measures, and at the same time, we enhanced the triage system. And through these modalities, we were able to pick up more cases of TB, and not only picking up more, we sustained the services for both drug-resistant TB as well as the drug-susceptible TB. So what we are actually noticing from the Zambian chapter amidst COVID with all these measures put in place is that we sustained, we showed resilience, we showed responsiveness. And I would like just to underscore the one fact that the ministry could not do this all by themselves or by ourselves, but we did this with the helping hand of our cooperating partners from CDC, from all the organizations sponsored under the USAID, ETB, as well as the TB loan project in their respective provinces where they are working, they work tirelessly hard. Also, just to share with you that one of the provinces supported by Eradicate TB, this year, they have actually showed a 17% increase in their TB notification. And it's through these measures that we've put in place. So essentially together with our partners, we've shown resilience, we've shown innovations, and also responsiveness to a situation that had befallen us. So, Chairperson, I would like to end here.
Thank you very much, Dr. Lungu, for sharing the work that the Ministry of Health is doing and the strategies that have been put in place to combat the impact of COVID-19. We'll go straight to our next presenter, and our next presenter is Dr. Victorian Sonder. Dr. Musonda is the Chief of Party of the USAID-funded Eradicate TB project, which is implemented by PATH in Zambia. And she will take us through some of the highlights regarding how the project has been working in support of the Ministry of Health, and specifically ensuring that TB treatment success rates are maintained despite the COVID disruptions. Dr. Musonda, please.
Thank you very much, Dr. Mugala. Good afternoon, good morning, good evening, everyone. So I will share my presentation on what has been done through USAID Eradicate TB project. So if we look at the first slide, Eradicate TB project is actually working in 6 of the 10 provinces in the country. And our project goal is to reduce TB-related mortality by 50% in the intervention provinces by the year 2022. And then we have 2 objectives. The first one is to increase the number of individuals that have been screened for TB in the target provinces by 50% from the baseline in 2016. And then the second objective is to increase the TB treatment success rate by 80 to 85% and even beyond in our target provinces. Next slide. So if you look at this slide, the TB treatment success rates have actually remained above 90% throughout the COVID-19 pandemic in the provinces which we have been supporting as Eradicate TB. And of note, you will notice that the proportion of the cure rates against the treatment completion has been improving even during the period of COVID-19. And this shows that we were able to consistently follow up and monitor as well as evaluate the response to treatment for all our patients. And the next slide. And this slide is just talking about the key interventions that we have used to maintain the high TB treatment success rates. At national level, ETB joined the Ministry of Health in the COVID-19 response through infection prevention and control, and also the health promotion committees that were established by the Ministry of Health. And we provided technical assistance to the team to develop some of the information materials on TB as well as COVID-19. And this also helped our staff in the health facilities to understand COVID, because initially they were avoiding even attending to TB patients in fear of contracting COVID-19. Then at the provincial level, we also supported the training of 510 frontline healthcare workers in COVID-19 and TB infection prevention and control. And this was targeting the high volume facilities. And these health workers were actually followed up with technical support supervision, and we also provided mentorship just to ensure that there was adherence to infection prevention guidelines for COVID. And then at the district level, even in addition to what Dr. Lungu has mentioned, the data review meetings, these regular data review at all levels, they were not just happening at the national level, but at the provincial and the district, including the health facilities. We were able to identify the performance gaps that were related to TB patient monitoring, and then we were able to address them immediately. Next slide. Then at the health facility level, the month drug dispensing during COVID-19 also ensured that there was no disruption in the treatment to the patients. And then we were also able to provide airtime to healthcare workers to follow up their patients, just to make sure that those that were due for services at the health facilities were informed, and also results were also communicated to these patients. And they were also able to communicate with the community-based volunteers to ensure that they followed up those patients. Then we also have a patient tracking form, and this also helped us because we were able to, at the facility level, the health workers were able to identify those patients that were due for services at the health facility. They were able to inform them and also inform the community-based volunteers to ensure they followed up those that failed to show up for their appointments. And then apart from that, at facility level, we've also been supporting the motorbike courier system to access laboratory services and also for patient monitoring. And this helped us to enhance, to ensure that health facilities were able to refer sputum samples, because we have some health facilities that are not able to examine some of the sputum specimens. And also the results feedback was also provided through this courier. And then at the community level, apart from the community-based volunteer, the health facility staff having access to the patient tracking forms, even the community-based volunteers also have access to that form where they are able to identify those patients that are due for services, and they were able to actually follow them up and ensure that they came to the facilities to be monitored. And then the other activity which also helped us to achieve these success rates is the pairing of the patients with the community-based volunteers. This one actually enabled the volunteers to ensure that they followed up the patients, and it also helped to build relationships. And it also enhanced accountability by the community volunteers because they were connected to those patients. And then we also had the dots by member of the patient's household. This also helped the patients to receive support from the family, and they were able to stay home. And this also enhanced the treatment adherence. Then the provision of the reusable face masks to the community-based volunteers and also the hand sanitizers. And this was also, in addition, there was orientation that was conducted to the community-based volunteers in the COVID-19 infection prevention and control, while we also provided mentorship just to ensure that they got the understanding. This also helped them with the PPEs that they received. It also helped them to have confidence to follow up some of the TB patients in the community. Thank you very much.
Thank you very much, Dr. Musonda, for giving us those highlights, particularly looking at how Eradicate TB has been able to work in collaboration with the Ministry of Health to ensure that treatment success rates are maintained despite the disruptions caused by COVID-19. With that, we'll go to the next presenter, who is Kristian. And Kristian is the Ascent Project Director, KNCV Tuberculosis Foundation. Kristian, now that we have heard from our colleagues in Zambia, I wonder if you could provide higher level perspective of what is happening across sub-Saharan Africa. How are innovations helping to maintain and advance gains in the fight against TB despite the pandemic environment?
Thank you so much for having me and organizing this session. Yeah, because what we heard in by the last couple of speakers is that indeed that interruption of health services and the need for social distancing due to the current COVID pandemic, it poses a challenge for healthcare workers, for patients to provide that essential care. But in contrast to those new challenges that are imposed by the COVID-19 pandemic, it also presents an opportunity to strengthen virtual and digital modes of treatment and care. For instance, according to the WHO, the Stop TB Partnership and the Global Fund, the use of digital tools for patient support can hereby help to ensure that the health and the well-being of TB patients continues to be prioritized. So in the next couple of minutes, I would like to share what innovative digital treatment approaches are currently being utilized and how and do these indeed create new opportunities for TB care in sub-Saharan Africa. And you can go to the next slide, please. And follow on next one. Because if you look at even before the COVID pandemic, many people affected by TB already face challenges to receive appropriate treatment support. Often facilities were the places where that support was provided, but travel for patients to these facilities was burdensome. Many live far from qualified clinics, and clinics could be crowded with long waits and little doctor time. And it often negatively impacted the ability of people affected by TB to continue with work. And it has only been worstly affected by COVID, where speakers before me already said that the prioritization of COVID-19 led to a reallocation of nurses, even beds for MDR TB patients, and the fact that patients were not promoted to come to the facilities, but were actually promoted to stay at home and often be provided with a month's worth of treatment for self-administration of treatment at home. So how can we adequately support our TB patients during and throughout their treatment, even in these complicated environments? Next slide, please. One of the big enablers for potential innovation in treatment support is the fact that in the last 15 years, over 72% of our global population gained access to a mobile phone. And that also created opportunities for digital technologies to support tuberculosis treatment. For instance, in 2018, the WHO published a handbook on how digital technologies could support medication adherence. And medication technologies or digital adherence technologies, those are technologies that can empower patients to take their daily medication at a time and place that suits them best, but also provide real-time information to health staff to provide individualized care. And in the next couple of minutes, I will highlight 3 of these technologies that have been used in sub-Saharan Africa, but also in other countries. Next slide, please. The first technology is called 99 dots, and it's actually DSTB or drug-susceptible TB medication that are often packaged in blisters, are put in an envelope and are wrapped in an envelope and are provided to patients at the first visit when they start the treatment. And it could be that a week's worth of medication is being provided to a patient, or a month, or even longer. Next slide. Every day a patient takes the medication, a hidden unique code is being visualized, it's being revealed by opening the blister. And patients send a message to a toll-free SMS number, so it's at no cost, and everyone with access to a phone can use this technology, or call a toll-free number. And that works at very large scale. In the next picture, you see a mine worker from Tanzania very remotely using his feature phone to call in 99 dots. And large-scale implementation experience has been gained in India, but also Uganda, the Philippines, Bangladesh, Myanmar, and Tanzania use this digital approach. And what is a benefit from this approach and from these adherence technologies is that the health staff on their end can be triggered by actionable messages. So in the next picture, you'll see a message that can be received by the patient or by the healthcare worker, or actually it jumps now, but it doesn't matter, with actionable information. Another technology is a smart pillbox. It's more flexible than the 99 dots because all kinds of medication can be put in this box. And here you see a patient in Ukraine that receives a box. The box can be provided with many days of medication. And every day the patient opens the box, it sends a message to the healthcare worker that the patient opens the box. Lastly, and maybe the most known one, is the video supported treatment, where the patient records him or herself or have a video conversation with a healthcare worker remotely on a distance, so that to show that the medication is being taken and that healthcare workers can provide the necessary support in case of problems with the medication. It can either be a live conversation, and some countries have moved and shifted during the last couple of months towards this via WhatsApp or via other existing communication channels, or patients are sending their videos to the healthcare workers. If we move to the last slide, what we can say is that these are three technologies. They have been used in various contexts and in various countries, and they are used for various types of patients. There is no one technology that can solve all the issues, but they can create new opportunities for TB care and sub-Saharan Africa, because it can help ensure that the health and the well-being of TB patients continues to be prioritized. It is very important to have an integrated approach, and that is also something that the Ascent project seeks to envision. We are a project that is funded by USAID with various partners such as SPART and the London School and the Aram Institute, and across 5 different countries, Tanzania, Ethiopia, South Africa, and the Philippines and Ukraine, we are looking and evaluating the use of these digital adherence technologies. So please feel free to also access our website, and I'm very happy to receive any questions after this presentation. Thanks so much for your attention.
Thank you very much, Kristian. Obviously, there's a lot to unpack in this conversation, and I do hope that we can have time. We're going into a question and answer session right now, and I hope that we can do this more, talk about any questions that the audience will have related to the presentation that you have just made. So with that, we are going into a question and answer session. I'd like to remind the audience to post any of the questions that you may have in the chat box, and these will be presented to the speakers to respond. We have one question which is for Charlotte. And the first question is there any initiative supported by USAID for dual disease screening, COVID and TB?
Thank you so much, Nanthalile. So that's a very interesting question. So we don't have, for example, a centrally funded initiative, but what we have done, and we have a couple of great examples at country level of the missions working with partners in national TB programs and ministries of health to pretty quickly integrate dual screening into programs. And a great example is in Burma, where our partners had to shut down, and the NTP had to shut down the mobile TB clinics temporarily because of COVID. But then when the COVID response included opening up fever clinics to check for COVID, they then diverted the TB screening to the fever clinics. So you had that's an example of using the COVID response to integrate TB. And then in a couple of countries in Africa, for example, Uganda and Mozambique, we have examples where the TB programs are now integrating COVID-19 screening into their communication materials and their job aids and whatnot, so that there's never a missed opportunity when TB screening is happening to also look for COVID. So I would say there's not really a centrally funded or mandated initiative, but we definitely are seeing these sort of organic, very country-led responses come up across our portfolio. Thank you.
Thank you very much, Charlotte. Do we have any questions? Yes, so there is another question here from the audience. How was the TB mortality and TB treatment success rate compared with previous the previous period? I guess this is a question that could go to Dr. Lungu or Dr. Musonda. How has the TB mortality and TB treatment success rate compared with previous period? That's the question.
Thank you very much, Dr. Mugala. I think to respond to that question, the TB mortality in the periods, it has actually remained the same. We haven't actually seen a marked increase or reduction in the TB mortality. It remained about 4% over the period of COVID. So it has not actually changed or gone up during the COVID period. Thank you.
Thank you. There is another question here. Do most TB patients have symptoms, and what are, do most TB patients have symptoms, and what are tuberculosis symptoms? I guess maybe the participant is trying to find out whether they are the symptoms with COVID, I guess, with the COVID environment, whether there are changes in terms of the symptoms that one may present with when they are also presenting with TB-related symptoms. So the question simply says, do most TB patients have symptoms, and what are the tuberculosis symptoms?
I think for the patients, yes, they do have symptoms, and the symptoms are not very different from those that are presented with COVID-19. And usually these are fever, they are night sweats, there's chest pain, sometimes they have a cough. And even when it comes to, some of them may even have difficulties in breathing, which is sometimes very difficult to actually even distinguish between TB and COVID. And most of the patients, even for the COVID, usually there is more marked difficulty in breathing than in TB, unless somebody is at an advanced stage. But we also have seen those that have presented with, maybe they may not have a full combination of these symptoms at the same time, because maybe they, especially those that are clinically diagnosed, sometimes the symptoms may not be as clear-cut as those that are seen in typical TB. Thank you.
Thank you very much, Victoria. We have another question here from the participant, and the question reads, there are many similarities with how TB has affected my country in the past. Therefore, I'd like to know what are the possibilities for these programs cooperation to be extended to Latin America. I guess maybe the participants would want to know what are the possibilities for cooperation or collaboration between these programs with Latin America. That's my understanding. I hope I'm correct with this question. Dr. Lungu, maybe something that you'd like to talk to?
Yeah, so thank you very much, Chairperson. I think from our side as the National TB Program, we are happy to share our lessons with others, and hopefully through these best practices or lessons learned, we could help other programs with the TB response amidst the COVID. One of the things that I think we should all be aware is that if you look at what is actually happening in Europe, where the cases are beginning to rise, this is likely to happen across the globe, depending on the weather patterns or many other factors that may be driving the pandemic. So I think we still need to stand ready and also share the best practices so that in an event countries are experiencing a rise in the cases, lessons learned from other countries like Zambia could be applied in those circumstances. I think this is what I would like to share at this particular time. So we are happy to collaborate and share our best practices of how we sustained our TB interventions. Thank you.
Great, thank you, Dr. Lungu. There is a follow-on question which you might want to tackle, and it's about the number of community health workers that we have that have helped in this initiative in Zambia.
Thank you very much, Chairperson, and also for that question. I would like just to start with the MDRNAs. So one of the things that Zambia was privileged with and helped to sustain the DRTB services amidst the COVID is that at the beginning of 2019, if not early 2018, Zambia recruited MDR nurses. So these are skilled nurses, and these were deployed at community level to support the MDR patients at the community level, and also to conduct screening, contact screening for the DRTB patients. So besides the community volunteers, we have skilled personnel in the cadre of MDR nurses who've been providing community interventions. So from among various partners, we have community volunteers who also have been trained prior to the COVID times, and also where we had to readapt their skills during the COVID times for them to continue providing the services without themselves risking their lives, and also them being a vehicle of transmitting the COVID within the communities. So from the various partners, we drew quite a number of community volunteers who assisted with the targeted screening and also delivery of drugs to patients that would not be able to come. Then also within facilities, we also have community volunteers who were able to support us with phone calls, SMSs to track the patients at community level. So in a nutshell, we have both volunteers and also the skilled workers at the community level. Chair, I submit.
Thank you very much, Dr. Lungu. We'll go straight to another question. This is for Charlotte. And it says, you mentioned that in some settings, only 50% of the gene expert machines have been diverted from TB diagnosis to COVID diagnosis. Why is this, and why aren't settings able to do both? Is this because there is not enough machines or time to do both? Is it a lack of TB test kits from Coveted? Are health workers overworked and unable to perform both tests? Or is there another reason or combination of reasons?
So that's a very good question, and my answer would be all of the above. So I think there are issues of, you can use the same platform, of course, the same machine to run both TB and COVID tests, but I think in some places where COVID testing has become centralized, those machines end up being diverted more for COVID when they were previously used for TB. So I think there's a real issue there. You have many more samples arriving, particularly in urban areas where outbreak investigations are happening. This has been the case in Mozambique, for example. I think there's just the laboratories and the laboratory technicians. I'm sure Dr. Lungu could say more about this, and perhaps Dr. Musonda are somewhat overwhelmed. And so, you know, it just, I mean, we've even seen this with in the HIV world with multiplexing. Sometimes, you know, some samples get prioritized over others. And I think there's also sort of an issue with specimen transport. If there's, depending on the specimen transport system, if it's quite fragmented and COVID is seen as an emergency response, you could have a situation where you have a lot of specimen transport resources being devoted to COVID that maybe at one point were going to TB. And so therefore even the samples aren't arriving, but I think it's very context specific. I hope that's helpful. I don't know if Dr. Lungu would want to add to that.
Yeah, thank you very much, Charlotte. Also, just to say that even in our settings, when the COVID-19 cartridges were available, some of the machines had to be prioritized for COVID testing. But one of the things that, and the reason this was so, and why the TB program also accepted and supported such a call, was that the COVID response was an issue of national importance. And by responding to COVID, we're also responding to TB. Why do I say so? I say so because when there's an outbreak such as COVID, the TB programs tends to suffer. So we needed also to support the COVID response so that we could remove that threat, and also we could be on track or restart our TB activities. So in a nutshell, the TB program needed to support the COVID response, in the sense that if we did not do so, we risked the COVID pandemic escalating further to a point that we may have even experienced a total disruption of services. But one of the things that I would like just to underscore is that the beauty is that within the ministry, we had to actually have a lot of consultations among various departments. And one of the things I did appreciate is that our colleagues were very receptive and accommodative of the concerns raised by the TB program. So we were able to go back and forth on the round table, discuss on how best to operationalize the multi-disease testing with regard to COVID-19. In the initial phases, of course, the priority was COVID first. Later on, people realized the impact that we're going to have on TB if the total disruption. So through the dialogue and also showing some of the numbers from the TB program, we were able to actually now test both TB and COVID. So in the areas where the gene experts were identified for COVID testing, even TB testing continued. One of the measures that were put in place is that the operation hours of that particular lab were extended from maybe a normal 8-hour shift to a 24-hour shift, and more manpower was allocated. So in essence, through these modalities, we were able to cater for both COVID as well as TB testing using the gene expert machines in those areas. And the other modality that we use is what Charlotte was talking about, of rerouting the TB specimens to a different site. So this did occur in some facilities where TB specimens were rerouted to a particular facility where there was fewer specimens. So through this, we're able to continue with testing. With all this said, we still had some hiccups. And I think through the TB situation room, we were able to quickly pick up some of these emerging issues and go back to the round table, pick up a phone call, discuss with the colleagues, and a way forward was chanted. And through this, we had positive outcomes that sustained both COVID response and TB response. Thank you very much. I submit.
Thank you very much, Dr. Lungu. We have one more question, and this is to Kristian. How has COVID-19 affected the Ascent project startup in Ethiopia?
That's a very good question. The Ascent project started mid-2019. So let's say, luckily for us, we did not start our underground implementation activities, but we were preparing to start our project in Ethiopia. So what had happened is that many of our preparatory activities were postponed. What also happened is that some of the technologies that are used in the Ascent project, and this is also something that we are evaluating within the Ascent project, are coming from other countries, are coming because they are being produced, for instance, in South Africa or in other places. So as all the flights and shipments were also halted, importations were difficult. So that also led to some delays. I think on the other side, there was also this big notion that there is a need to come up with at least alternative treatment approaches that could be digital. And I think in that sense, it had a higher priority on the agenda to seek for technologies that can support patients on a distance. As of a couple of weeks ago, we started our first study meetings in Ethiopia. So the project is starting up in Ethiopia.
Thank you very much, Kristian. We have time for one more question. Is there regional or international cooperation among countries in sub-Saharan Africa to tackle COVID and TB? Are lessons being shared from country to country? So I would ask any of the speakers to respond to this question. It's absolutely important. Charlotte, would you like to take it up, or Kristian or Dr. Lungu?
Chairperson, perhaps Charlotte and Dr. Musonda could take that up.
I'll be honest, I'm not aware of any formal regional collaborations to share lessons learned, although I think that's a very good idea. I do believe that there's one platform in South Africa that I've heard about that is being used to share, for example, more specifically on the clinical management of COVID-19 that other countries and clinicians in the region are able to access. But I don't know anything about the more like programmatic aspects and how those lessons are being shared. My sense is that it's happening somewhat organically and informally at this point.
Yeah, Chairperson, I would like to come in as well just to share one experience. I think through the African Union and also through a regional project called the Southern Africa TB Health System Project, which is in 4 countries. There were opportunities that were created to share experiences. I was privileged to be one of the speakers among the WHO colleagues and other program officers. So there were quite a number of platforms that where we shared best practices and how to continue essential services and what countries were doing. And to that effect, the African Union in the Watch magazine, they have actually published the Zambian story of how we continue the TB services. I could share later on. Thank you.
Thank you very much, Dr. Lungu. We are almost at the end of our time, and I'd like to close our conversation with one final question for each of the speakers. And so in just very briefly, in just 60 seconds, can each of you share one opportunity that we have now amid COVID-19 to ensure impact for long-term TB care? In very, very, very briefly, and anyone is free to start.
Thank you, Dr. Mugala. I think for me, one of the opportunities that we can actually use is that there is the National TB Situation Room that has been created, and this has actually created a lot of competition, and also it holds even the districts, the facilities, as well as the provinces accountable for the performance. So this is an opportunity that is also helping us to work with the implementation levels to ensure that they sustain the gains and ensure that they are monitoring and also ensuring they are also doing the evaluation as well as documentation of the efforts that they are making at their level. So I think this is a great opportunity for us, and we'll continue to work with the National TB Program to ensure that even the gains that have been made are sustained so that we can actually be able to contribute to the global TB elimination efforts. Thank you.
Chairperson, I could come in. For me, I would like to just share two opportunities that the COVID-19 has brought. Number one is just to build on what Dr. Musonda has brought out. One of the things is that we are seeing a more acceptance of the electronic platforms such as the Zoom, Blue Jeans, the Teams. And this, we've been able to reach the far places remotely and provide the technical support or even engage in a meeting remotely. So for me, that's one opportunity, and it's a more cost-effective means. The second opportunity is that for a long time, I think the TB program has been advancing the agenda of infection control and prevention. And through the COVID, I think we've seen a much more acceptance, and also facilities, even the community themselves, adhering to some of the IPC measures. The use of masks applies to both COVID-19 as well as TB. So to a large extent, I think we are also benefiting from this pandemic in the sense that more people are accepting and adhering to the IPC measures. I submit and I thank you, Chairperson.
It wouldn't be strange that my opportunities are, of course, related to innovations and digital. And I think that this pandemic showed that the real-time data, the importance, and we were already on the forefront as TB, and we can do even better because we see the importance of real-time data to effectively fight against this pandemic. And again, also this training, the remote training, the Zoom meetings, that suddenly became such an important element to build capacity of all of our staff and organizations and the users on the ground. That's wonderful that is implemented in such a short period. Two last things: the awareness raising, ability to share relevant and up-to-date information via massive communication channels such as WhatsApp. The WHO started the WHO WhatsApp helpline with adequate information that can be easily made accessible to everyone and can be adapted for each country context. That's something new. And lastly, those innovative virtual treatment approaches that we really see accelerating in various countries. Those are the big opportunities that I see.
And those are all great ideas. I think the only thing I can think of that I would add is that it would be interesting to see how we could harness the power of screening for COVID to improve screening for TB. I know even now, the couple of times I've gone to the doctor since the epidemic started here in the US, the first questions that I'm asked are COVID related, right? And we talk about the importance of trying to integrate screening at every point of entry to the healthcare system. And I think that in some places that's often thought of as this like insurmountable, like we couldn't really possibly do that, but I think we can. And I think COVID is showing us that we have to. And, you know, TB is still the leading infectious killer in the world. And so when we learn from COVID that we can do that in an emergency response, maybe we need to think about how we could carry that forward for the longer term TB response and just really utilize all those opportunities to do the screening. Thank you.
Thank you very much. Unfortunately, we have run out of time, but I'm sure you all agree with me that this has been very informative and really a timely discussion. I want to express my gratitude to all our speakers for sharing their time and expertise with us today. It was great to hear your perspectives on what is happening locally and globally. For those of you who are tuning in from around the world, thank you for your engagement and for all your thoughtful questions. Unfortunately, we weren't able to get all of your questions, but we hope you will continue to follow our series of webinars to hear more from our experts within and outside of PATH. So whether PATH is new to you or you have followed our work for a long time, we certainly appreciate you taking the time to join us today. Please do stay in touch and keep safe. Thank you very much and bye for now.
Bye-bye.